It is a great pleasure. I am honored and humbled to be in front of you today. I did not think I would ever have this honor. This organization has given more to me and my family than we can possibly give back, and I'll get to some of that later. And having said that, but what I wanted to focus on today is this organization and what it's meant as far as keeping people young and keeping people out of the good old days. So the mission statement of the Midwest Surgical is there. I'll let you read it. But the highlights of that is regarding about especially young surgeons in the Midwest. Now, we can probably get rid of the Midwest part of it because we're becoming more and more of a national organization. But the idea of this was to promote the highest standards of surgical practice, especially among young surgeons. Young surgeons have ideas. Ideas make old surgeons uncomfortable, and that's the nature of the progress of surgery. It's also, in the last part of that, is also making sure that there's highest quality social program plan with the children and families, and I think we've all seen that along the way. So the good old days were, all that good and all really good, and everybody talks about it. So, you look at the present, and you see what things goes on. Well, in the vast majority of measurable outcomes, both in surgery and not surgery, things have improved. By any objective way you can push them out. So maybe in a little more subjective way, it's a picture of Elton John. Now most of us grew up in Elton John, Daniel, Someone Saved My Life Tonight. We think back in ways that the good old days were good. And you look at him today and you think, well, poor old Elton's had a rough life. So you remember the good old days in a way, but the good old days really weren't all that good. I'm not sure that was an improvement over the good old days, so I can just say that sometimes we look at things a little bit differently, and I'd rather watch them the other way than he is presently. Keeping on the train of aging rock stars, this is also one of my favorite quotes along the way, that we remember the good old days in a certain way, but they weren't always that good, and the future isn't as bad as it seems. If you look at this for some statistics of this is just mortality data from the CDC and the MMWR, the mortality and weekly reports. And you can look over since 1935 to 2010, over that 75-year period, the age-adjusted rate even though the number of deaths went up, the age-adjusted rate for deaths continues to come down. And the crude death rate also, not even age-adjusted, continues to come down. It's at the lowest point it was ever measurable in 2010. Something's going right with this. If you look at the disparities in race even at this point, at this time, it's never been closer for the disparities in the race have gone on. So we've also had the less fortunate, or the people that have traditionally not got the best medical care or shown problems with their health care. That seems to be closing. And this data, I suspect, will close even more over the next several years. This data is through 2010. And even the decrease in death rates over the 75 years varied by age. We did the greatest good, it had the greatest impact in the young people, reducing death rates in the young people and giving them the most amount of life. That way life expectancy went up. But even at the far end, if you look, there's substantial increases or decreases in death rate by age, even in people of the age 75 and older. I mean, you're still talking about substantial differences in the death rate. So I submit to you that despite all the things we hear about, all the things being bad, the statistics say we've never done better in many areas. People live longer. The death rates are lower. So we must be doing something right along the way besides from the good old days. If you look at some disease-specific data, this is the age-related data for hyperglycemic crisis as the reason calling death, and it just continues to come down. Age-adjusted and crude, they both continue to come down along the way. We take better care of diabetics. We understand the pathophysiology better. We make it so they just do better in the long run, and it continues to go down. A little more surgical, if you look, these are the 5-year relative survival rates for those cancers listed there. Every one of those statistically better in 2004 to 2010 than the 1975 to 1977 data. And some of them, the increase is quite remarkable. There's obviously still work to be done on liver and intrahepatic bile ducts, and the esophagus is still only 20%, but clearly we've made progress. Neoadjuvant therapy, better surgical techniques, better perioperative mortalities with treating these. We do less blood loss, less respiratory failure, less surgical infections. And again, if you look at stuff that I deal with a little bit more, if this is an English study, fracture rates, you can see that the mortality for hip fractures, this is in-hospital mortality, and the fracture rates continue to go. When you look at the age-adjusted rate, the rates haven't gone up very much, but the mortality rate is going quite down when you look at especially at age-adjusted mortality rates. Even though the number of hip fractures is staying relatively stable. That is with an increase in population. But once again, hip fracture. Now, this is in-hospital mortality. That maybe simplifying it some. But again, these are trends just from 1998 to 2009. And then finally, if you look at trauma overall and the ISS score, the injury severity score, as a function and the survival and trends in mortality, you can see in every section, every one of these cohorts, less than 9, 9 to 14, 15 to 24, and the most severely injured patients of over 24, we continue to do better. Now, there's obviously work to get done, but we keep changing the mortality rates, better trauma systems, better understanding of resuscitating patients, better understanding of surgical repairs and what we can, how we can do it, how we can do damage-controlled surgery, the effects of multi-modality surgeons working at the same time. You've had to put up with this is the third chief of a service from Detroit Receiving Hospital giving a talk in the last 2 days. But you can see I was spoiled by my Dr. Santucci and Dr. Vady and the help they give us in the trauma service. Well, I love this quote, and it really does come through. Because you can see when you give a new idea, like, this is what happens when Farley comes up with some new educational program at the Mayo that costs $26,000, and I look at it and I wince. And I'm trying to figure, and I'm hoping not too many of my residents in the room listen too closely to that educational performance, because I have to wince. But you start thinking about, boy, that's a good idea. And when you come in contact with it, the amount of pain you feel does relate to your age and maybe your inflexibility. Just a couple of things that went through in my time, really, from when I was a resident. Now, who remembers diagnostic peritoneal lavage, right? You have to be a senior author. You honest to God do, right? Because the residents, last time I did one of these, you thought I was putting an aortic valve in the resuscitation room. Because everybody wanted to see it. The nurses wanted to see it. The radiation techs wanted to see what the hell was going on. It took us about a half an hour to find a catheter because we hadn't used one in 9 years. And so we used to do this all the time. We put the catheters, and everybody talked this was a good technique. It would show if there was blood in the abdomen, you could tell right away. And it was a good technique, but we put that catheter in every single organ you can imagine. We put it in the bowel, large and small. We did an amniocentesis one night at the receiving hospital. I guess that was positive for the lavage. The FAST exam, the use of ultrasound and CT scan as some result, clearly identified people that had blood in their abdomen, fluid in their abdomen quickly, and it was a major, major advance in trauma and the ability to move trauma patients through without further causing trouble. Here's another one I like. Dr. Wilson taught me this one. Subxiphoid pericardial window is a diagnostic if there was a cardiac wound. Right? Some people describe doing this in the emergency room under local. Now you really got to think about trying to do that, versus getting an echocardiogram out and putting it on the heart and see if there's fluid around it. And as that technology keeps getting better, it's easier and easier to do it. I can even do it and figure out there's a pericardial infusion. It's markedly better for patients. That was not a good old days for the patients. They might have been sort of when dinosaurs ran the earth around for the trauma surgeons, but it clearly wasn't the best thing for the patients. This is one I love. I got drilled into me during my residency that you never, ever, ever give just one unit of blood. If you have to give blood, you give 2. What the hell was that? Does that make any sense at all? If they need 1 unit, they need 2, right? You double the virus loads, you double the chance for blood transfusion reactions. It never makes sense. I was just in a meeting at receiving. We were discussing the blood transfusion at receiving last week. And one of the measures is that how often we can transfuse only 1 unit of blood is a good marker. We've come completely opposite. So in those days, no matter what you got, Mrs. Jones, you look a little pale, we'll give you 2 units of blood. Because you couldn't give 1, because it didn't make any sense, right? So I don't know where that one came from also, but that's clearly changed. We've changed that. We've reduced transfusions, understood transfusion pathophysiology much better. We've reduced the rates of transmission of viral diseases to almost non-existent in some populations. It just is better time than this. Well, with that, I'm going to take you through a story of one of the largest contributions that Dr. Wilson made to me, and then I took up and try to figure out how to measure resuscitation at receiving in our career. And so I thought I'd put this out as a marker of a story of how I think things got better. So it's both the use of end-tidal CO2, which is used ubiquitously in the operating room in North America. Every person who's attached to a anesthesia ventilator has their end-tidal CO2 measured. And also a little bit about bicarbonate administration and acidosis, but mostly on the first one. So bear with me. This is actually going to be a basic science talk for about 6 slides. And maybe I'll ask some of the past presidents some questions. Anyhow, The CO2 physiology, CO2, most people in the room know it's transported by three mechanisms: dissolved by bicarbonate, which is the vast majority of it, and also just really attached to hemoglobin. This particular equation should look familiar to everybody who's been through the college, where CO2 combines with water, which forming carbonic acid. It then redistributes into hydrogen ions and bicarbonate. This in a red blood cell, this equation goes very quickly because of carbonic anhydrase, which moves it along. And in the cell, the hydrogen ion binds to hemoglobin, and the bicarbonate ion goes out into the plasma, and chloride comes in, so the chloride in the red blood cells increase. It's called the chloride shift. The function of hemoglobin in CO2 transport is act for a buffer for the hydrogen ions. So hemoglobin has a significant, we think about it as a significant oxygen carrying molecule, but it has a huge impact on the acid-base status of a patient. Hence, it has a huge impact on the acid base of a patient, of a resuscitation patient. And interestingly, again, the totaling buffering capacity of hemoglobin is 6 times greater than all the other plasma proteins combined. That has also implications in transfusion. If you have low hemoglobin, you have low acid binding capacities. This cartoon hopefully will help with this. I'm going to start here, but if you have CO2 is very, very diffusible across cell membranes. It goes into the cell. Some of it is bound right to the hemoglobin, that secondary amount. Much of it goes through with the enzyme carbonic anhydrase to carbonic acid, but then is quickly dissociated into hydrogen ions, which then bind to the hemoglobin, and the bicarb is then sent out to the plasma, or on a chloride exchange transport. So this is the basis of it. So if you have CO2, it will go easily into the cell, and if it goes to hydrogen ions and bicarb, either with carbonic anhydrase around or not, you form a full amount of acid. This is exactly how a red blood cell works. However, if this is a neuro cell, it's a neuron, it's a hepatocyte, it's a myocyte, it doesn't work as well. It doesn't work well. It doesn't have hemoglobin to bind all these hydrogen ions. The other one of my favorite answers, and so if Dr. Zimmerman, who gave this, and some of the other students in the room, is this one of my favorite acts on rounds. It's one of those easy philosophical questions or physiological questions about acid excretion. You excrete acid 2 ways, one by renal and one by respiratory, but it's not close. 40 to 80 milliequivalents in 24 hours from acid secretions, renal, 15,000 or more if you're on a ventilator. So all acid base in the short run is respiratory. Why am I talking about this? Well, early in my career, when I was a senior resident, Dr. Wilson started fooling around with end-tidal CO2, and he had an idea that it had something to do with how the patient was being resuscitated, though we really couldn't quite figure it out. And so at that time, as in now, end-tidal CO2 has been used for these purposes, but it's mostly about is an endotracheal tube in place, is a circuit connected. Maybe you see it in a pulmonary embolus, it drops quite a bit. And also, if you have adequate CPR, you reestablish spontaneous rhythms doing CPR, it goes up. Well, as I said before, the diffusibility of CO2 is much higher than O2, and that makes the elimination of PaCO2 very sensitive to blood flow. That means cardiac output, much more than the diffusion across from oxygen across the blood. And you can see this is one of the animal studies many have been done, as the cardiac output increases along the x-axis, the y-axis shows the end-tidal CO2 also increasing in a relatively linear fashion. There's many studies that show this in both artificial and clinical settings. So the key of this is the difference between your partial pressure of carbon dioxide in your blood and your end-tidal CO2 is actually quite small. It's very diffusible. So in a awake, upright group, which maybe half the audience by now still is 0 to 2. As soon as you intubate somebody, you change that gradient quite a bit. It shows how you change the flow in the lung, and it is very greatly influenced by pulmonary blood flow. And again, if you look at a capnogram, where this is where the person starts to exhale, there's a large increase in the measured CO2 till it gets up right to the end-tidal, and this blow up here shows you that's usually 1 to 2 difference. Well, if things go wrong, things change a lot. And you can change the end-tidal CO2 or the partial pressure of CO2 in the blood by minute ventilation, but the difference between the two, that 1 to 2, is not really influenced by ventilation. Whether your PaCO2 is 40 or 35, your difference, if your cardiac output is normal, is about 2. I like this cartoon. It's not mine, but they quoted me in it, so why not put it up and show you what goes on. So this is a schematic of lung here, ventilation, and the blood flow to the lung. This is a normal, close matching of ventilation and perfusion. There's normal blood flow, normal ventilation. The blood comes in with a partial pressure of carbon dioxide at 46. It comes out at 40, the normal arterial. The end tidal, it mixes with 40-40, and it comes out at 38. The difference is 2 to 5. Okay, two abnormal situations. The first is where you don't have any flow to part of the lung, or the cardiac output is down. Because there's no flow to the lung, really, there's no end tidal CO2 here. It wouldn't really be zero, but there's really no end tidal CO2 here. However, since there's no flow going by it, it doesn't change. The other part of the lung usually picks it up. Usually picks up the difference, and so this comes in at 46, ends up at 40. The blood gas doesn't look that much different, but the end tidal CO2 is only 18. It's only getting half of what's coming out. So the difference is 22. Now, if I go back, remember that's markedly different than it would be if it was just 2. Conversely, if you don't ventilate the lung, but perfuse it, because of the non-ventilation on this port, the difference is only 6. This goes through at 46, that's true, but because it comes out at 43, it does not make that much difference. Again, it's the blood flow through the lung that greatly affects the difference in the end tidal CO2, with minimal effects on actually the partial pressure of carbon dioxide in the arterial blood. Now, why am I going through all this? Well, it's a picture of one night, well, actually, Vady and I were working on this. This is a high-velocity gunshot wound, a rifle just above the knee. This right here is the femur. And these two things here are 2 shunts I put in. The reason I like this picture is because they actually did come out red and blue. You don't see that very often. So this is an arterial shunt and a venous shunt across the vessels that have been completely obliterated. So there's flow to the foot, and we've got a little time. And the question now is, should I let Vady do stuff? Should I take the patient up to the ICU? Should he put an X-fix on? What's the decision you make in that time? So what do you use to make those clinical decisions? You use the vitals of the patient. You use how much fluid they got. They look coagulopathic, right? What's the blood gas look like? Those kind of things go on. When we were looking at that for a while, I started looking at it and saying, well, I started staring as I was doing this, Wilson's influence on me. I started staring at the end tidal CO2 monitors, and I realized they looked low when the patients didn't do well lately. So, because you got some time while you're staring there trying to figure out what to do with that shunts in. And so we looked at a bunch of patients when we looked at their end tidal CO2 that in patients that had trauma surgery within 6 hours of them showing up. And this is like the second of 4 of the major papers we put up. And some of the authors here are in the room, and some of them, virtually all of them, I think, except for Dr. Kalinj, is a member of this organization. And what it comes down to is we arbitrarily changed these patients' resuscitations into 3 phases. There was an initial phase where you got the first blood gas in the room, and then we compared it to the end tidal CO2 that was on the monitor that anesthesia went. All these patients were under general anesthesia. Most of them were quite sick. Average ISS was 28. And you can look here that this is the difference between the end tidal CO2 and the partial pressure CO2 in the arterial blood. So it's end tidal CO2 from the monitor versus a blood gas CO2 that was presented. And we divided it into 3 different portions. One was the initial one, first obtained in the ICU, first obtained in the operating room. And we looked at that. The post-resuscitation one is fuzzy, and I always got trouble with this when I presented this data, because it was when we decided we had caught up. Anesthesia feels pretty good, the blood's in, we've got the bleeding stopped. I agree that's a subjective point, but we felt good about it. The blood pressure normalized, and then the final was the final one coming out. So there's an arbitrary division of these 3 data points. However, in those people that lived, the difference was fairly normal for an intubated patient. Somewhere to 4 to 6. Again, in an awake upright patient, it's 0 to 2. But everybody who died, it was higher. Let's spur this on a little bit, because Dr. Wilson would say you have to write more papers, and he'd yell at your young person, you have to write more papers. That problem even showed up when on the patients who's had a blood pressure of greater than 100 in the room. In other words, these are people you thought were resuscitated, and again, if you look at the difference right here, those that lived, it was less than 10, and those that died, it was greater than 10. Even I can remember that number. So that pushed us on to look at a much bigger group of this, and we started feeling better and better about our stuff, so we started getting, our titles got sexier and sexier. A useful intraoperative mortality marker in surgery. Starting to feel good enough to start making comments, in the titles. Then you're feeling pretty good about yourself. A big study. You can see the statics up there. A lot of laparotomies, a lot of thoracotomies, some craniotomies. We did like I said, the ISS on this actually came down 22. But here's again, the difference between the end-tidal CO2 that lived, died in the OR, died 24 hours later in those three resuscitation phases, initial, post-resuscitation, and final. And again, it's very striking. Those who lived, it's under 10. And you can see that if you could really resuscitate them, the number actually dropped. It went from 10 to 9 to 7.5. Yet if they died in the OR, they never went down. They started getting worse. And even those that died greater than 24 hours later, or died within 24 hours, showed marked differences also within 24 hours. Less so for those that died later. Some of these deaths were sepsis deaths that were before. Nonetheless, their numbers were greater than 10, and I suggest that probably inadequate resuscitation at the time led to multi-system organ failure that had them die 10 or 12 days down the line with us fighting the ventilator in the ICU. And again, even if their blood pressure was greater than 100 at that time, the end-tidal CO2 difference below 10, and those who died, especially in the first 24 hours, way above 10. So we thought that the gradient was, if the gradient was greater than 10, you should look at what else is going wrong, even with the normalized blood pressure. And it could be used for an additional factor in the decision for damage control surgery. And so what we came from this, and I think other authors have picked up from it, is this was better care in the operating room. It was a really elegant pickup that Dr. Wilson noted with this differences, and then we kind of took and ran with it in that everybody's already intubated, everybody's already got an end-tidal CO2 monitor attached to them. All you have to do is read that number. If these people are sick enough, what ISS is a 22 undergoing laparotomies, everybody gets blood gas, pretty much. You have to take the PaCO2 at the blood gas, subtract the end-tidal CO2, and if the number is higher than 10, it's not good. Now even I, at 2:30 in the morning, can figure that one out, and so I thought this was pretty useful. This is an example how I think surgery moved on. It was a simple concept recognized by a group of people taking care of patients, and this has been useful for me, absolutely, for decisions for damage-controlled surgery in the operating room from time on. Which gets me to the last part of the talk. So this is a great Henry Ford, and this is actually really, really apropos because there are people that are both 20 and 80 that continue to keep learning. In my surgical career, I had three large influences on my career. The first picture there is Dr. William Clark. You can blame him that you know me. He's the one that got me interested in surgery at Syracuse. He ran the burn unit. Dr. Clark passed last year. But he was a Midwest surgeon. He worked in the Upper Peninsula of Michigan for a while and it was an Air Force surgeon before he ended up in Syracuse running the burn unit. He's the one that got me interested in surgery. So the middle picture is Dr. David Fromm. Dr. Fromm was my chairman both as a medical student at Syracuse, upstate, and my chairman as a surgical resident in Detroit, the Detroit Medical Center in Wayne State. And then the last picture there is a former president of this organization, Dr. Wilson, who had the most influence on me, and he's the reason I'm still in the Midwest to some extent, and he's been a constant counsel to me. The rest of the people that have influenced me and have helped teach me are far too numerous to go. I owe them all a great debt. I also owe a great debt to the people that are around me at Receiving Hospital today, my partners, the subspecialists that help me, and they all make the jobs much, much better. Finally, my family. Man, did I do better on this gift exchange than they did. So this is a picture from 2001 at Geneva Grand Resort at the Midwest Surgical. Now the one thing that's irritating to my children and I is my wife's picture never changes much, and I change greatly. And I'm going to prove that to you in a second. Anyhow, this is their group. Emily seems really happy with herself with that golf club. One of the measures of the Midwest Surgical is the ability to have a scientific program and have great family get-togethers. My children enjoy this meeting immensely, so does my wife. The bonds formed here will be a lifetime, and friends have been really formed by that. And we look forward to it every year, and I think that's the spirit we have to keep going with. We need young people in here. We need to keep pushing the good times were good, the future is even better. Everybody developed their own styles in this time. So just so we clear, so every one of my children developed skills along the way. Just for any Northwestern guy, that is a Northwestern guy being taken down by a University of Chicago wrestler on that. Jeff, Elizabeth in her language skills, which are amazing, and her ability to play her tennis in college. And that's one of the coolest pictures I ever saw. So that's a homecoming court player that still wanted to be in the marching band, so was playing in her dress at the homecoming parade at halftime. I thought one of the coolest ever. And so I am incredibly grateful to my family for the support they've given me through the years. They actually seem to like each other, too. This is up at the Great Lakes Shipping Museum a few years ago, and they're all clowning around. The only person that's been at every single Midwest Surgical with me is my wife, Julie. So this is, again, her at the time. I don't look too bad there when I look back. I didn't think I looked good at the time, but now when I look back on it, I was better. Thank you, Connor, for that, whatever picture you put up for that is. From the Santas. So this is our picture. She's the only one that's been, I am incredibly indebted to her. She took care of me. She took care of the children. I could not have done what I've done academically or personally without her support. This is 25 years later. Now you make the judge of that. That's like a vampire. Okay, she just did not age, okay, from where it is, right? So I think my final couple slides is what I love this Rodney Dangerfield line as far as, what you did to your family. Again, there's a picture Connor did. I do think that the good old days weren't all that good. I do think there's always better times ahead. There's always challenges. Every era had its challenge. Every era had its problems that seemed insurmountable. But they continue to go on. I think the data supports that. I think we continue to be observant. We continue to look at our patients, and we continue to push the science forward. In the meantime, we also have to realize it's a balance with our families, with the rest of life that goes on. I think this organization, as well as any, emphasizes that very well. It shows it well, it lives it. And with that, once again, I am humbled and I am honored to be up here, and that concludes my presentation. Thank you very much.